Good evening, everyone. I'm Dr. Samir Bansal, and it gives me immense pleasure to just introduce this whole topic today, and to today's webinar. And today's webinar is actually on one of the most common, challenging, and often controversial uh, topic: the infections encountered in the hospital, the ventilator-associated pneumonia and hospital-acquired pneumonias. Now, why is this important? Because despite so many guidelines and all, it continues to be associated with prolonged or, significant amount of morbidity. And we will be answering a lot of questions through today's talk, namely diagnosis, guidelines, treatment, and so on. I would first like to thank ICS for this particular initiative, especially Dr. Rajesh, Dr. Chawla sir, and Dr. Amita Nene ma'am for bringing us onto this platform. I would definitely like to, thank all the panelists and all the speakers for tonight. And without further ado, I would just like to call on our speaker and introduce him, Dr. Debraj. Can we have the slides on, please? So Dr. Debraj is MBBS, MD, DM, Pulmo and Critical Care. He's also done his EDRM, MNAMS. He's the head of the department, Manipal Hospital, Kolkata. And without further ado, Dr. Debraj, the dais is all yours, and please go ahead.
Thank you, Dr. Samir. So, I have been assigned today the topic of ventilator-associated pneumonia, the diagnosis and management. So, over the next 20 to 25 minutes, the topic which I will cover on, first of all, what do we mean by ventilator-associated pneumonia? Little bit discussion about the epidemiological aspect and the Indian burden of the ventilator-associated pneumonia, the common risk factors, etiology, pathophysiology. I will not go into details. So I will straight away go into the clinical presentation diagnostic, different diagnostic tools, both clinical, serological, and the biomarker based. And treatment, I will focus on the most common types of ventilator associated pneumonia organism and the targeted treatment based on that. Newer antibiotics which are in the pipeline for MDR VAP, little bit discussion about the VAP prevention bundle. So when we discuss the importance of ventilator associated pneumonia, and around 20 to 36% of all hospitalization is due to the ventilator associated pneumonia. And if you go to the mortality aspect, it has a wide variation from 24 to 76%. Why this wide variation? It is because of the different pathogens associated. If someone has an MRSA, probably the mortality will be relatively lesser. But if someone has an MDR Klebsiella, probably the mortality will be little bit on the higher side. Now, what do we mean by the VAP? It is the nosocomial pneumonia which occurs 48 hours after endotracheal intubation and mechanical ventilation. So for VAP, or to coin the term VAP, the patient has to be on mechanical ventilation for at least 48 hours. Now, there may be a common term which is also hospital acquired pneumonia. So hypothetically take a patient is admitted with a COPD exacerbation. Now 48 hours later he started having some kind of symptoms such as increase in oxygenation, fever, rise in CRP, all those kind of things. So we will call that patient having hospital acquired pneumonia, not the ventilator associated pneumonia. Risk factor for ventilator associated pneumonia, any comorbidity, elderly patient, and particular association is with the neuromuscular blockade, which we frequently use any kind of paralytics for any kind of lung rest. Any chronic lung disease, previous history of hospitalization, patient who has been on tracheostomy for a long duration of time, and who is on any kind of enteral feeding. Now, if you go to the data between 2005 to 2013, actually, on the contrary, the VAP number has been on decline. This is an article which I have been portraying from JAMA 2016, and if you see there is a decline. So why there is a decline? Either it may be due to better implementation of preventive strategy, or there may be difference in the VAP definition. So all the hospitals are cautious and they are not notifying the exact number of VAPs. So probably the number is on the higher side, but hospitals are not portraying. So I will start with a case. This is a 22-year-old male who is just admitted with a tetanus. He was put into ventilation, no kind of fever, all the counts were normal, just intubated because of tetanus. 10 days later, he started having high grade fever with purulent secretion coming out of the ET tube, WBC count of 22,000. And this is another patient case 2, 24-year-old female with SLE who was put into mechanical ventilation again due to airway protection because of seizure. She was afebrile in the beginning, but 4 days later on, he again started having high FiO2 and PEEP requirement. She had fever, but absence of purulent and abundant secretion. The chest X-ray of both the patient, initial chest X-ray were normal. But if you see the later chest X-ray, the first patient X-ray is relatively okay. In the second patient, there is a right upper lobe consolidation. Now, there are three terms which are very important definition. Number one is ventilator associated condition. So a patient who is stable on ventilator after 48 hours, if the patient has FiO2 requirement increase by 0.2 or PEEP requirement increase by greater than 3 for 2 consecutive days, then we will coin this term ventilator associated condition. On top of ventilator associated condition, if the patient develops temperature of greater than 38 or less than 36 and WBC count of greater than 12,000 or less than 4,000, or a new antibiotic is started, then I will call this term as infection related ventilator associated condition. So first term is ventilator associated condition, second term is infection related ventilator associated condition, and third term is possible ventilator associated pneumonia on top of IVAC or infection related ventilator associated pneumonia. If there is purulent respiratory secretion, what we mean by purulent respiratory secretion, greater than 25 neutrophil or less than 10 squamous epithelial cell, or positive culture from sputum, ET aspirate, or bronchoalveolar lavage anywhere. So three terms: ventilator associated condition, infection related ventilator associated condition, and possible VAP. Now, if you see the case 1, patient did not have any increase in PEEP or FiO2, so did not satisfy the definition of ventilator associated event or IVAC or VAP. So although the patient has developed some kind of pneumonia or increase in purulent secretion, I cannot call this term as ventilator associated pneumonia. But on the case 2, because the patient has increase in PEEP or FiO2 requirement, so the ventilator associated event I will call, and because of presence of fever, WBC greater than 14,000, change in antibiotic for 4 days, IVAC. And later on, when purulent respiratory secretion came and ET tube culture revealed Pseudomonas aeruginosa, the same patient, the diagnosis was changed as probable VAP. There is another criteria which was used previously, the Johansen criteria. What do we mean by Johansen criteria? Mandatory one, there is on chest X-ray, presence of new infiltrate or progressive infiltrate, plus at least 2 of the 3 clinical features. What do we mean by 2 of the 3 clinical feature? Fever greater than 38 degrees Celsius, leukocytosis or leukopenia, and third one is purulent secretion. So the case 1 satisfied the Johansen criteria as the patient has new infiltrate plus fever, leukocytosis, purulent secretion. So it is very difficult to tell which criteria to take. This one, another one very important, the clinical pulmonary infection score. What do we mean? There are 6 components. First one, temperature. Second one, oxygenation. Third one, tracheal secretion. Fourth one, blood leukocyte. Fifth one, chest X-ray. And sixth one, tracheal aspirate culture. So there are different scoring. If the CPIS is greater than 6, then we will call it as ventilator associated pneumonia. I will not go into the details of the pathology or the, but little bit discussion about the microbiology is required because it is directly related with the treatment. If you see the Indian ICU data, the top organisms are Acinetobacter, Klebsiella, Pseudomonas, followed by MDR E. coli and Staph aureus. And if you see the ICMR data also, the carbapenem resistant Acinetobacter, Enterobacteriaceae, Pseudomonas, these are very common. And there are also different organisms associated with early VAP and late onset VAP. Early onset VAP are usually antibiotic sensitive. Prognosis better. Usually these are associated with Streptococcus, enteric GNB, and MSSA. Late VAP are usually associated with MDR organisms, Pseudomonas, Acinetobacter, and MRSA. Worse prognosis associated with a higher mortality. Now, if we see the other kind of diagnostic scorings, Apache 2, like all those scorings also we can use. Biomarkers, procalcitonin, it will help in stopping the antibiotic treatment. It will also help in differentiating between bacterial and non-bacterial infection, but it will not help in initiation of the antibiotics. C-reactive protein, widely available, rises quickly in infection, useful trend marker. Soluble triggering receptor M1 and IL-8, IL-1 beta, MR, Pro, ADM, these are all for research purpose and for prognostication, not used regularly in our day-to-day practice. If you see the diagnostic criteria I already discussed, CT scan thorax, it is gold standard. If you can demonstrate the pneumonia in the CT scan, nothing like that, but always associated with a cost, radiation, and transferring a patient who is requiring high FiO2 and PEEP, always associated with a decrease or difficulty in oxygenation. Chest X-ray, very sensitive, but with obviously with less specificity. Nowadays, with more and more use of lung ultrasound, we are getting experienced. Unfortunately, not yet in guideline, but it will definitely come in the latest guideline. ET aspirate, widely used, contamination risk, all those things, bronchoscopy specialists are required. Chest X-ray, always it cannot identify all the pneumonia in all location and difficult to diagnose the small consolidation. Also subjective variation of interpretation. Lung ultrasound, newer tool, easily accessible, no radiation, cost effective. It is a very promising tool if we can demonstrate dynamic air bronchogram in the USG, also associated with, if you see the B lines developing all on a sudden, you will think of some kind of pulmonary edema. But if you see B lines developing only on a single side, you will always think of some kind of pneumonia. Also, if a patient develops unilateral pleural effusion, then you will think of some kind of parapneumonic effusion. And also, if you see that there is another score called as SEPI score. SEPI score, same like the CPIS score mostly, but it incorporates procalcitonin in it. So in addition factor is procalcitonin. Apart from that, tracheal secretion, culture of tracheal aspirate, temperature, infiltrates on chest X-ray, oxygenation, all the things are there. And both the cases had a SEPI score of greater than 5. So a SEPI score probably was relatively better in predicting the VAP. Biomarker I already discussed. CRP and modified CPIS score are associated with a probably gradual development of VAP. Procalcitonin, again I'm reiterating the fact it has a role in de-escalation of the antibiotics, and in some patients who are not responding with a normal procal, you can think of fungal or some other kinds of infection. Threshold value for culture, it will vary according to the method. Obviously with bronchoscopy, the required sample, the threshold value is relatively lower compared to the other methods. Real-time PCR, the problem with the biofire and all those things, it is unable to detect or differentiate viable from the non-viable organisms. Also, antimicrobial sensitivity, although there are reports in biofire, but not that much sensitive compared to the conventional drug and culture sensitivity. It is also significantly susceptible to the false positive detection, presumably by contamination from any non-pathogenic bacteria. Multiplex PCR time to result was 26 hours shorter compared with the conventional culture. Expensive, so distance between the sample site and the laboratory matters. Difficulty with all the rapid microbiological assay, as I told you, that difficult to differentiate between the colonization and the culture. Breath TX, breath analysis, these are newer methods, but more of a research purpose. Now, these are the aspects of diagnosis of ventilator associated pneumonia. The later part is the treatment. So the latest guideline was the ITSA guideline 2016, but lot of separate guidelines have come regarding the management of isolated organism. Now, if we go by the guideline, so should all patient with ventilator associated pneumonia we will go for bronchoscopy? Answer is no. It has been found that semi-quantitative culture is as good as the bronchoscopy to diagnose VAP. So in all patients, should we send procalcitonin? The answer again is no, because procalcitonin will not help in initiation of antibiotic therapy. It will only help in de-escalation of the antibiotics. Should soluble triggering receptor expressed on myeloid cell 1 should be sent? Answer is no. CRP, again, we use regularly in our day-to-day practice. All of us should be honest that we always use CRP plus clinical criteria to decide whether to initiate or not initiate antibiotic. But in the guideline, still CRP doesn't have that much role. And if you see the near, as I told you, so what are the methods what we should do in reducing or preventing the VAP? Number one is the subglottic suction, which we will discuss again in our panel discussion. Subglottic suction. Avoid intubation as much as possible. Use NIV, but we should not avoid intubation up to that extent that even a delay intubation, patient may have aspiration. So we should detect appropriate time for initiation of mechanical ventilation. Patient should be as much mobile as possible. Bedside chest physiotherapy, very pertinent and important for preventing ventilator associated pneumonia. Ventilator circuit, we should not change it regularly unless the circuit is soiled or malfunctioning. Routine change does not reduce the rate of ventilator associated pneumonia, and after every patient it is not mandatory. Humidifier, very important source of infection. Single use disposable humidifiers better, but they are more expensive, but we should at least clean and sterilize the humidifier between all the patient. Suctioning, always hand wash before and after the procedure, clean gloves, single use catheter, inline suction. Normal saline should not be used routinely. It causes more desaturation, does not involve removal of secretion, and potentially dislodge the bacteria. Cup pressure, very important point. We should maintain it between 20 to 35 centimeter of water. It should be monitored every day 3 to 4 times at least, because more and more cup pressure will lead to subglottic stenosis. Ultra thin polyurethane endotracheal tube, these are the newer ET tubes which should be used. Most of the hospitals are using also this. Now, if we go by the semi-recumbent position versus supine position, semi-recumbent position is always associated with less chances of VAP. So positioning is also very important. Head end of the bed elevation at least 30 degree will reduce the chances of VAP. And if semi-recumbent position, it will at least reduce the VAP incidence by 34%. Oral care, very important. Perform ET suctioning only when clinically indicated. Oral hygiene, every 4-hourly toothbrushing. These are mandatory things. Oral hygiene care. Toothbrush, as I told you. Probiotic and symbiotic therapy shows promise in reducing infection, but more studies are required whether we should routinely use probiotics or not. Silver coated endotracheal tube doesn't reduce the rate. Kinetic beds doesn't reduce the rate. Prone positioning should be used, but for reducing VAP regularly, prone positioning is not required. Stress ulcer prophylaxis, again, very much controversial. Those patients who are receiving enteral nutrition not required regularly. So we should not use regularly H2 blocker or PPI unless it is absolutely required, because it will lead to selective digestive tract decontamination and increases the risk of pneumonia. Suctioning, again, we should use only inline suction, and in ARDS patient close suctioning, but no difference normally between open and close suctioning for the reduction of rate of VAP. Now if we go straight away to the treatment part, monotherapy, when the patient is having no MDR risk factor, early VAP, what we can use? We can simply use ceftriaxone and levofloxacin or moxifloxacin. So target is MSSA plus non-resistant gram-negative bacillus. When we have an MDR risk factor risk or high mortality risk, we should use piperacillin, tazobactam, imipenem, meropenem, cefepime plus anti-MRSA, which are the anti-MRSA agent vancomycin or linezolid. In septic shock, we should add aminoglycoside or anti-pseudomonal fluoroquinolones. Aminoglycoside also may be added. And definitive or directed treatment, stop antibiotics if no organism found, and we should de-escalate as soon as possible. Novel antibiotics, ceftazidime avibactam, nowadays the most commonly used antibiotic for ventilator associated pneumonia. Remember, it does not protect Acinetobacter. It is only effective against MDR Pseudomonas aeruginosa, ESBL enterobacteriaceae, and KPC producing organism. Meropenem verbobactam, it will be again no activity against Acineto as well as Pseudomonas. Ceftolazone tazobactam, MDR Pseudomonas and ESBL enterobacteriaceae, limited activity against again Acinetobacter. So if you see, most of the organism doesn't have that much activity against Acinetobacter except the colistin and the sulbactam combination. So Indian relevance, ceftazidime avibactam and colistin sparing regimen urgently needed given 98% carbapenem resistant Acinetobacter. Inhaled antibiotics which can be used, inhaled amikacin but not used regularly, inhaled colistin, very important in using the patients with bronchiectasis and in those patients who is having the recurrent colonization. So the advantage of inhaled therapy, targeted lung delivery, fewer toxicity, particularly the nephrotoxicity and the muscular toxicity associated with colistin. It will also reduce the duration of the IV antibiotic, no gut microbiome disruption, but the limitation is not in current guideline and very much expensive, also associated with bronchospasm, which is very important for respiratory patient. If we see the VAP in Indian ICU, I already told you the most common pathogen is Acinetobacter. It varies between ICU to ICU. In some of the ICU, the Klebsiella and the Pseudomonas are also very common. So if what we should do, how we should monitor in Indian aspect, we should do serial chest X-ray if anything is developing many of the patient, fever, leukopenia, leukocytosis, purulent sputum or positive bell or ET culture. These are the things what we should do in Indian context. And as I told you, if you have Acinetobacter baumannii, then you should give colistin plus carbapenem, it should not be used alone, plus sulbactam, and emerging one is the cefidarocol. Tigecycline should not be used that much because the lung penetration of tigecycline is not that much. If the patient is having recurrent colonization, then we can use inhaled colistin also in addition with the IV colistin. And also in those patients who are having myopathy, we can use inhaled colistin. Klebsiella, ceftazidime avibactam, if no MBL, metallo-beta-lactamase. Aztreonam avibactam, if metallo-beta-lactamase is positive. Colistin-based combination, if those agents cannot be used. Monotherapy should not be given. Pseudomonas, again ceftazidime avibactam, anti-pseudomonal carbapenem plus aminoglycoside if the patient is not having any kind of renal dysfunction. MRSA, linezolid is better over vancomycin. Remember, daptomycin not for any pulmonary infection. So patient improved on antibiotic, culture positive, ventilator associated pneumonia. Patient improved, culture negative, stop antibiotic. Patient worsened, culture positive. Why antibiotic is not working? We need to find out the cause. Patient worsened and culture is negative, then we need to find out other causes of worsening like ARDS, organizing pneumonia, vasculitis, infection outside the lung, drug-induced toxicity, or pulmonary embolism. Future direction in VAP research, standardized diagnosis, universal VAP diagnostic criteria. A long time has gone. There is no new guideline of VAP diagnostic criteria. Biomarker guided criteria. Some better biomarker compared to procalcitonin may come in near future. Inhaled antibiotics, apart from the colistin, other inhaled antibiotics may come. AI may help us in predicting the VAP. Indian research agenda to find out newer antibiotics apart from ceftazidime avibactam and antimicrobial stewardship. The behavioral change interventions are very important. So key practice point, we should diagnose early and treat promptly. CPIA score till date is the best possible one. Assume that you are dealing with MDR in Indian ICU. So empirically, even if we should use Acinetobacter, colistin sulbactam plus anti-pseudomonal compliance. De-escalate as soon as the culture depot is available. Bundle compliance, be strict with the hospital staffs. Monitor and adapt legally and regularly monitor the Apache 2 guideline. This is the Indian Society of ISCCM guideline which has come. Most of the recommendation I already discussed with all of you. Thank you very much.
That was a lovely talk, Dr. Debraj. I think you covered a lot of aspects. I know the time was short, and this is a topic which actually people can go on and on about. And of course, there's so many different guidelines, but you summarized it pretty well. So thank you so much for that, Dr. Debraj.
Thank you, Dr. Samir.
Yes. So with that, I think we'll just now open our panel. Can I request the organizers to just put up the slides for my panelists, please? Yes.
Yes. So Dr. Samir Bansal sir, he has done MD, DNB, EDRM as well as IDCCM. He is a senior consultant of pulmonary critical care and interventional pulmonology working at Apollo Hospitals, Bangalore. He is also an associate professor of Apollo Health Education and Research Foundation, senior consultant and clinical head of bio chest and sleep specialist, and he has a lot of publication around 45 publication and 5 book chapter, member of various societies, and his area of interest is severe asthma, COPD, ILD, pulmonary rehab, BPF, hemoptysis, TB, and antibiotics.
Thanks for that introduction, Dr. Debraj.
He's going to moderate our discussion tonight.
Thank you so much for that introduction. Yeah, so I would just like to introduce all my panelists, and in fact today we've got a brilliant, table or chair of panelists, and everyone is an expert and pretty well known. But for the sake of you all, I would just like to introduce. We have Dr. Amrish Patel. Is a consultant pulmonologist and intensivist. He's the senior intensivist at Sterling Hospital and is the director of Breathe Chest and Critical Care Clinic with more than 15 years of experience. He's also the treasurer of ISCCM Ahmedabad chapter. He's the chief intensivist in liver transplant program at Sterling Hospital. and is widely experienced in, I think, variety of critical care situations. He is also a teacher for DNB teaching program and has been a panel and faculty member for various national and state level conferences. Welcome, Dr. Amrish. We also have Dr. Jacob George. He is the medical superintendent and senior consultant critical care. He is a heavy intellectual, if I must say. He's had a lot of papers and 26 book chapters to his name. He's co-author of the book OSC in Critical Care, which is a great book where, practically you can all have that thing. He's the speaker at various national and international critical care conferences, pulmonology conferences, and workshops. And his area of special interest is, of course, infection control and hemodynamic monitoring. Welcome, Dr. Jacob.
Thank you. Thank you.
We also have Dr. Kumar Utsav. He's the consultant pulmonologist and critical care specialist at number of leading hospitals in Varanasi. He's done his MD in respiratory medicine from BJMC Ahmedabad, and he's been working with MDR and XTR tuberculosis patients and achieved National Young Scientist Award for presenting the largest study on XTR TB patients in NAPCON in 2014 and even at ERS. He's got numerous article publications and a textbook publication to his credit, and he's also been a faculty panelist speaker at various national and international conferences. Welcome, Dr. Utsav. And finally, we have Dr. Vidushi Rathi. She's MD Pulmonary Medicine at Vallabhbhai Patel Chest Institute, Delhi University. She's also DM Pulmo and Critical Care and Sleep Medicine from AIIMS, New Delhi. She's done fellowship in sleep medicine and also has European diploma in adult respiratory medicine. She's currently the assistant professor at pulmonary medicine at VP Chest Institute, Delhi University. She has specific area of interest in ultrasound and critical care, asthma and ABPA. She's been recognized widely, and again, a lot of publications, I think 70 publications already, and I know this will just keep growing on. So yes, this is my esteemed panel, and I welcome you all.
Thank you so much for that wonderful introduction.
This was an excellent talk, and I think still, because the time was pretty short, so for the sake of interest the audience, a lot of those questions will be trying to go in depth. Some of those may be repetitions, but again, this is all for, I think, sake of a healthy discussion. So, Dr. Amrish, if I may ask you. Doctor, I think Debraj already mentioned the ATS ITSA guidelines 2016. So what exactly was this guideline for VAP? And what do you think is the biggest misconception that the clinicians still have about diagnosing VAP?
So first of all, thank you, Dr. Amita and ICS panel for inviting me and become a part of this wonderful webinar. And return to your question, Dr. Bansal. So, first of all, nicely presentation taken by our Debraj sir. So, by the definition, it is clearly mentioned that any development of the pneumonia that occur more than 48 hours after patient having intubated or patient receiving mechanical ventilation. But every definition is not 100% proper, but there are certain misconceptions we are seeing. We have seen at least 4 misconceptions. First is that we consider whenever we send the endotracheal culture in our routine practice, we have sent culture. So positive endotracheal culture, that doesn't mean VAP. Like there are 2 case scenario. We consider not each and every case VAP. So whenever we have received the endotracheal culture positive, we should not consider as a VAP, because colonization is a rule, not an exceptional. So most of the times we have seen, most of the time our patients are only colonizer. They are not having a lung shadow, or we consider as a lung inflammation. So these are the major misconception prevalent in our ICU. Another misconception is whenever we see a new infiltrate on chest X-ray, we consider as a VAP. But you have seen in ICU, there are other factors also contributing for development of new radiological sero, particularly like atelectasis or pleural effusion, or sometimes we have seen as a pulmonary infarct also. So not radiological every shadow should be considered as a VAP. Another thing is that early VAP is from MDR bugs. So you should start two anti-pseudomonal coverage and vancomycin as per guideline. So we have seen early pseudomonas early VAP less than 5 days. It is mostly sensitive bugs. So not directly jump to the higher antibiotic, because you can very well manage with the initial ceftriaxone or levoflox or moxifloxacin. So these are the another misconceptions. And finally, we have seen, like we have practicing in ICU. So if lactate is up and there is on patient is on ventilator, so we consider as a VAP. But we have to think that there are other causes that also occur in ICU, like epilepsy, COTY, sinusitis, drug fever, C. difficile, ischemic gut. So these are the other factor we have to see. They are the contributory factor for the development of the fever as well as development of hemodynamically instability. So only lactate up is not considered, and patient is on venti, we should not consider as a VAP. So there are 4 misconceptions we are routinely seeing our day-to-day practice.
No, absolutely great. Just for the interest of audience, just to summarize, VAP is basically any pneumonia rising more than 48 hours after intubation. And more importantly, it remains a clinical radiological syndrome supported by microbiology, not otherwise. And one of the most important diagnostic skill is often recognizing when the patient does not have VAP. So not everything should be labeled VAP. So I will leave with that message. Dr. Jacob, this I think everyone encounters. Almost every ventilated patient eventually develops fever. Secretions are a rule. Infiltrates may be there. At what point do you decide this is VAP rather than VAT or ventilator-associated tracheobronchitis or maybe pulmonary edema or atelectasis or whatever?
So again, just as Amrish sir said, we have to look in the patient as a whole. And second thing is probably the most important sign that you have is a progressive infiltrate in a patient who is becoming sicker and sicker. And you have an increased ventilator requirements. So first thing, you should have a fever. All the causes of fever, other than the infectious causes of COTY, epilepsy, C. difficile, etc., has been ruled out. And you are seeing that the infiltrates have been increasing. Your patient looks sick. You have leukocytosis or leukopenia. Along with that, you also have thrombocytopenia. Your inflammatory markers are going up, and again, the oxygenation requirement is also going up. So in those cases, you will think that this has to be VAP. In the case of VAT, usually you have an increased secretions, but again, the patient usually is not that sick. And again, the oxygen requirement is even unless for a tube means when the secretions accumulate, you don't have much of an oxygen requirement. Now to judge the infiltrate on chest X-ray, that too in a supine frame in a ICU, it's quite tricky. So I think probably serial X-rays, or again, better than that, nowadays we all do ultrasounds. So if you can do an ultrasound and you can find out the consolidation there, that makes a good sense.
No, absolutely. So, Dr. Jacob, very well said. I think one of the major important things is a lot of times people do confuse the ventilator-associated tracheobronchitis with VAP. But the major thing is, when the infection has left the airways or descended from the airways into the parenchyma, it is affecting the gas exchange. So practical discriminator is actually not the sputum color. It is the evidence that the infection has moved on from the airways towards the parenchyma. So that is the major thing. And of course, you also have to take into account all the other things such as pulmonary edema, wherein your ultrasound can help, and atelectasis. Moving on to another topic, CPIS. So Dr. Utsav, what is the CPIS criteria, even though Dr. Debraj had mentioned it in detail, and how relevant do you think it is in modern ICU practice, and do you guys still follow this in your ICU practice routinely?
So CPI's criteria was beautifully described by Dr. Debraj Jash in his presentation. The leukocyte count, the fever, the temperature, the X-ray shadows, and oxygenation and tracheal secretions. Right? These are the things. But relevance is somewhat IDS. The IDSA guideline do not mention about using CPIS as a criteria for escalation or de-escalation of antibiotics. So my take would be that yes, it's a good research tool because there is a difference in the inter-observer variability. It's a good research tool and an adjunct, but you cannot rely it on stopping or escalating antibiotics or starting antibiotics for that matter in our day-to-day practice. Our clinical suspicion is much more important than using CPIs currently. That would be my take on it.
No, absolutely. Yes, it was majorly devised, I think, at one point of time to just diagnose VAP. But more importantly, it is useful to organize all the information rather than, judging causality. In fact, it can be used to prevent omissions, not to replace clinical reasoning, as you rightly pointed out, that clinical judgment still remains the major criteria to diagnose VAP. There is no one tool. Dr. Vidushi, I think you mentioned, it was mentioned in your summary slide that, lung ultrasound. So this question is very apt for you. How useful is lung ultrasound today? And can it realistically outperform portable chest x-rays for diagnosis of VAP?
Lung ultrasound, how useful? Yes, I would definitely say very useful. So it has now come as a bedside tool that we have. We have extension to evaluate that patient. But when I say to replace anything, to outperform, I don't think we want to outperform or replace anything. We all are looking for tools that will help us diagnose. So I would say it has a lot of benefits in the form of the fact that you can, as Sir was previously saying, comparing whether it is actually VAP. Do you have a consolidation, or was it a mimicking effusion which you were confused with? So ultrasound has a lot of role in terms of identifying consolidation, identifying effusion, identifying pulmonary edema, which confuses us a lot of times, especially on X-rays. But I would not say it is there to replace X-ray. X-ray does have its role, especially that that same X-ray is being seen by every faculty, while that lung ultrasound is being done by possibly the resident at the bedside. So experience matters in ultrasound. Even though studies do say that inter-observer variability is very less, I would still say practically there could be a little bit of difference in assessing consolidations. So what it very easily identifies is B-lines pulmonary edema. It identifies effusion very well. It would never help you identifying a progressive pneumonia or a cavity. So I don't think it should replace, but yes, it has a very important role.
No, very nicely put. I do feel that yes, ultrasound has its own benefits, especially for that peripheral lung pathology. That is where the X-ray may not really help us. But yes, it's not really good at answering, is this definitely a bacterial VAP? If I must say. And yes, one of the things is now with this thing and with the the evolution in technology, I think everyone should get their hands on ultrasound. Just go at it, especially all the pulmonologists. I'm sure critical care specialists do know their ultrasounds, but all the pulmonologists also should attend all those ultrasound workshops and get themselves upskilled. Dr. Debraj sir, so you took a nice talk. So again, you mentioned regarding the various VAP bundles basically for prevention. Now, according to you, sir, which component of VAP bundle has the strongest evidence? Head elevation, subglottic suction, sedation interruption, early mobilization, oral fluorexidine. What do you feel, sir?
Sir, all of the things which you just told right now has got very strong evidences. But if you ask which has the strongest evidence, so strongest evidence is oral hygiene and regular hand washing at frequent interval. So when we talk about oral hygiene, it may be by the chlorhexidine or it may be some by other agents. But the important thing is that the oral hygiene should be done meticulously. So many a times our nursing staff, they don't use toothbrushes, they do not inspect the inside of the oral cavity. Now coming to the other aspect like head end of the bed elevation. So head end of the bed elevation, again, it will have a role in preventing the aspiration or the micro aspiration, but it is not that important as if you ask for the strongest evidence. Subglottic, as you already told, the subglottic suction important but not that strong. Sedation interruption is very important because as you mobilize your patient early, and even how much sick your patient is, at least we should give a sedation holiday in the early morning hours, not only for the VAP prevention, also to have a look at the mental status of the patient, whether the patient has developed some kind of encephalopathy, or many patients are on also some kind of anticoagulation, whether they develop some kind of. So if you ask the strongest evidence, head end of the bed elevation and early mobilization, as well as aggressive physiotherapy and sedation holiday, as well as oral chlorhexidine, all of them are very important aspects of the VAP bundle.
Oh, absolutely, sir. In fact, one of my early mentors, he always used to say the strongest bundle is actually not, one product or anything. It is actually a full liberation bundle, and every safely avoided or shortened day of intubation is actually a VAP prevention intervention. So, yeah, agreed with all of those. And one more follow-up question to you, sir. What about the selective digestive decontamination?
So selective digestive decontamination was earlier encouraged as one of the more important aspects of the VAP prevention bundle. But nowadays, it has been found that selective digestive decontamination, if we go by the recent publication, do not have that much role in VAP prevention. It may have a role in certain subset of patients in who have been particularly having some kind of neuromuscular disability like myasthenia gravis, or if we ask for GB syndrome. In those subset of patients, certain selective digestive decontamination has been tried, which has been found to be relatively useful. But if you ask me overall, in all subset of patients, selective digestive decontamination does not have that much role in VAP prevention.
No, absolutely. I think that the cluster trial in the Australian ICUs also echoes the same thing. There is no benefit in mortality, although there may be slightly relevant benefit into this. Dr. Amrish, now moving on to the diagnostics part of it, do you feel that respiratory samples should always be obtained before starting antibiotics, even if a patient is in septic shock?
Like in any condition, first of all, we have to see the patient scenario. If my patient is sick, I cannot wait for sending the secretion. Like survival sepsis guidelines, you have to heat hard, heat fast. But whenever, because sometimes what happens, there are nowadays many issues. Collection center, boy will come if you order a blood culture, or you order for endotracheal sampling. There are always delay, but my delay should not be affect the outcome of the patient. So it is preferably you should send a culture before starting the antibiotic. But if I think by delaying the sending the culture, my patient will harm more, then I have to start the first dose of antibiotic. So what we think, like in our ICU, there are mucus extractor are always there. So we, whenever we think about there is a change of purulent secretion, patient having fever, so we always ask nursing staff, just take a sample first and store in a cool place. When or if any consultant is coming to the round, and if they ask to send the culture, then we have collected the sample, and and we send the culture. So but unnecessary delaying of starting of antibiotic should not be delayed. I think it should be simultaneously rather than one over the another. So it should be simultaneous.
No, absolutely, sir. If I may, cultures before antibiotics is actually a stewardship principle, but antibiotics without delay in shock is a survival principle. And usually good
Yes.
ICU systems achieve both in parallel.
Yes.
So Dr. Jacob, an interesting question and an important question, which I think a lot of people do still not know that, what's to follow. So endotracheal aspirate, mini ball, bronchoscopic ball, which gives the best balance between practicality and diagnostic accuracy?
When it comes to practicality, you have to think what is available round the clock 24/7. So obviously, the endotracheal aspirate is easy, and it is least invasive actually, and is repeatable, and that's what I recommend for most ICUs. When it comes, so even if you see that there's a ProVAP trial, etc., there's no difference between the minimally invasive or invasive ball, unless you say that you have a localized or a specific lobar consolidation and you want to go to that area. But usually, as we know, VAP is not like that. So it shouldn't make a difference whether you want to go, whether you should do a bronchoscopy. So patients on who have VAP will already be on higher FiO2. So discounting that, going for a bronchoscopy is a bit risky. So first of all, I prefer endotracheal aspirate. Then yes, if there is expertise where I can have my RTs in, I'll go for a mini ball. And probably I'll go for bronchoscopic ball only in the rarest of the situations where I have a diagnostic dilemma or something like that.
Right. I think very nicely put, because all the guidelines, in fact, till date, all suggest that ET aspirates are usually adequate. Of course, all the other more invasive, or rather, the facilities or the diagnostic modalities which are not available around the clock, such as a bronchoscopic bowel, they should be done whenever you have to localize, or there is a possibility of alternative diagnosis, or when there is a possibility of unusual pathogens. So that is the take-home message amongst all of these. Dr. Utsav, should quantitative culture still be considered the gold standard, or with the advent of these molecular diagnostics, have they overtaken these quantitative cultures?
Okay, that's a very, very important, interesting question that is actually being asked in all the modern ICUs in big cities where quantitative PCRs are available readily. Not in small towns where PCRs are not so frequently available. But the important point is it's not culture versus PCR. It is culture the way it should be. I feel is culture plus PCR, because culture has its own place of identifying a pathogen, giving a susceptibility, and giving you differentiating between colonization and infection. That is the role of culture. But the problem with culture is the report comes after 48 to 72 hours. With the advent of PCR, the result is available. We can identify a pathogen within hours and start a treatment accordingly in few hours time and get the right approach. So a PCR helps me start smart, and a culture helps me stay on the smarter course. That is how I see it. Start smart and stay on the smarter course. They are both adjuvant to each other. They are not versus. PCR versus culture is not the way I think it should be. These both should be synonymous.
Absolutely, I think you've hit the nail with that. The main funda is about integration, not really replacement. Culture, while it tells us what grows and what it is susceptible to, PCR can also tell us quickly whether and what genetic targets are present. So maybe an integrated approach is what is required. So a follow-up question on that, Dr. Vidushi, is Dr. Utsav also mentioned that most of these panels can identify pathogens and resistance genes within hours. So have they genuinely changed patient outcomes, or they are just, or not just, but mainly stewardship tools?
Sir, multiplex PCR, as Utsav sir rightly pointed out, is an additional tool in our armamentarium. The biggest advantage within multiplex PCR is that it gives you an early diagnosis. It's the time that it saves. We had already started empirical therapy. And if you get that result in time, it might help you in choosing the right therapy. So optimization. But if you're getting, as if it is in a peripheral place, you send a multiplex PCR and you get the report after 3 days, it's of no use to you. So in the right situation, if you can get the sample where it tells you an appropriate therapy, maybe you were giving piperacillin tazobactam as an empirical therapy, and instead on multiplex PCR, you find out that it's an OXA48 producing Klebsiella. In that case, you know that's not going to work. You would appropriately change it. Or on the other hand, multiplex PCR has a very high negative predictive value. Say everything came out to be negative. You have to reassess, what are you actually treating? Is it really a VAP that you're treating? So that ways it can help. But to date, there are no strong or good studies, great evidence that it actually changes patient outcomes. We need more data for that. This is a good tool, but to be used sensibly for optimization of therapy and possibly for de-escalation.
Yeah, no, absolutely. It's majorly a time to decision technology. In fact, one of the trials, latest 2025 Inhale trial, also said that yes, there was substantial improvement in antibiotic stewardship, but didn't really establish superiority in clinical cure. So, and you also rightly pointed out a test which reports in 90 minutes but is reviewed the next day has little value. So that's another thing. It should be taken into account as soon as possible, and the results should be, or rather, the treatment should be changed as soon as possible based on the results. So, Dr. Debraj, you have a patient who whatever endotracheal aspirate, you sent for a multiplex PCR, which showed multiple organisms, but your patient really appears clinically stable. This was just sent because the CRP was on the rising trend. What do you make out of it? How do you interpret any of these PCRs showing multiple organisms?
So I will interpret that result both clinically as well as radiologically. Now, suppose my patient is having some kind of cavitary consolidation and I'm getting a Klebsiella or I'm getting a Staph aureus, even if the patient has got a better clinical setting at the present, but I will still opt for the correct antibiotics like anti-Klebsiella or anti-staphylococcal. But if my patient is not having any kind of radiological worsening, patient is showing radiological improvement, patient is showing clinical improvement, then just getting a lot of Klebsiella, Acinetobacter, Pseudomonas, which we routinely get when we send the multiplex PCR, because those are very sensitive tests, and particularly because we all are pulmonologists. So our patient used to have repeated exacerbation, even if there is no history of hospitalization, but at least they have a number of episodes of exacerbation. So in those patients, unless those are clinically as well as radiologically important, we will not put that much importance on getting an Acinetobacter and giving a 10 days of colistin and sulbactam. So we will interpret the reports both clinically as well as radiologically.
No, absolutely. I think one of the take homes is that you always treat a detected organism when the syndrome, the burden, the microscopy, and the epidemiology align. And it's up to the clinicians, because this report may just list all the organisms. You have to see whether it's a pathogen, is it a colonizer, is it a bystander, or is it a contaminant. And all of these genes, resistance genes, also have to require a proper, careful interpretation. And one of the points which you mentioned, most of our patients who have structural lung disease, repeated exacerbation, that definitely warrants, I think, attention when interpreting all these reports. Dr. Amrish, now coming on to bronchoscopy, should this be routinely performed in suspected VAP or reserved for some selected patients?
In VAP, our endotracheal aspiration or tracheal aspiration is sufficient. But like in certain situations, despite of starting initial empirical antibiotic, depending upon our hospital or ICU antibiogram, still patient is not improving. Their ventilatory requirement is going up, radiologically worsening, or sometime what happened particularly say like neurological patient or those of our chronic pulmonary patient in whom sometimes they have retained secretion. So in this situation, if we do a bronchoscopy, then our two purpose is solved, like getting a proper secretion from a proper place, as well as we can bring out the secretion that will reduce the burden of infection in this type of patient. So not each and every patient, but those who are not response to initial empirical antibiotic or depending upon the hospital antibiogram, and some patient in whom we require to get toileting of the airway, in this situation we can go for invasive, means bronchoscopy.
Right. And Dr. Jacob, just a follow-up question on that. Which patients do you think definitely deserve a bronchoscopic sampling? And, when do you consider, no, my patient has to undergo bronchoscopy? Do you routinely follow some practices, some thresholds that you have? Dr. Jacob?
He's speaking.
You have to
muted
unmute
himself. He has muted himself.
Sorry. I'm really sorry for that. Sorry. So again, for most of the patients where I consider a bronchoscopy will be a patient whom I'm thinking who has a collapse and I want to remove that mucus plug or take the secretions out. That will be a most common indication for doing a bronchoscopy in VAP. Second thing is, if I have an immunocompromised host, where I'm thinking that this can be not a hospital acquired, the patient is on the ventilator, but still I'm confused whether it's a ventilator-associated pneumonia or whether it's something else, whether he has a pneumocystis, whether it's a mycobacterium tuberculosis, or is it a viral that is coming in, and I'm confusing whether it's as a VAP or HAP. In those cases also, I'd be thinking of doing a bronchoscopy. Third thing is, if I'm suspecting an alveolar hemorrhage or probably an organizing pneumonia, these are the cases where I usually think to do a bronchoscopy. Otherwise, most of the times we go ahead with endotracheal ET aspirate.
Absolutely. I think important thing is to recognize when to do it, and more importantly, when not to do it. And because in certain conditions such as ARDS, refractory hypoxemia, when your patient has a very high PEEP, unstable arrhythmias or shocks and all, that is where bronchoscopy can possibly worsen because of de-recruitment and all. So these are the things which should be kept in mind before embarking on a routine bronchoscopy, because as we already discussed, ET aspirate is also as good. But definitely certain situations wherein bronchoscopy can be invaluable. Dr. Utsav, one question to you, again related to bronchoscopy. Does BAL actually improve outcomes? Are there any studies on that, or does it simply increase your diagnostic confidence?
One has to understand that we have to understand that this is one of the biggest controversies of our time in our practice, that BAL, there are many studies who have randomized trials have been done which shows that BAL guided management does not change your ICU stay, does not change your mortality, and does not affect with that as compared to a normal diet. BAL clearly helps in microfilaria diagnosis, antibiotic de-escalation, identifying unusual pathogens and immunocompromised patients, and non-resolving infiltrates. That is the main goal. But BAL does not change your mortality, it does not change your ICU stay, so it does not affect that much. One, I would like to close my answer with one thing: BAL changes management more often than it changes mortality.
Right. So I think yes, because there have been a lot of RCTs also which have not really demonstrated a survival advantage over other non-invasive samplings. And majorly it's a decision quantity tool, not an outcome producing intervention by itself. So that is something which has to be kept in mind. So Dr. Vidushi, if you do a bronchoscopy, what is an ideal timing for bronchoscopy? Before antibiotics, immediately after, or whenever feasible? What do you think? And what is your practice?
So practically, it will depend on my indication for bronchoscopy. Because as Sir has already pointed out, a lot of times when we are actually going ahead with bronchoscopy, it's not because we are looking for an organism. It is because we are looking for an alternative etiology. If it's an alternative etiology I'm looking for, it doesn't matter. As soon as I think it is feasible, I would do it. However, if we think that it is some kind of an organism that is not growing in an ET aspirate, we are having contaminants. And if my patient is stable enough to wait for an antibiotic change, I might do it before. For example, this would be the case in a PCP, where ET aspirates results would not be as good, where a BAL result would probably be a higher chance. So I might consider, but clinical judgment would mostly direct me to start treatment and as soon as possible after that, do a bronchoscopy. Because in the end, what matters is that the patient gets a better outcome. I cannot withhold antibiotics for my patients to do a procedure.
No, absolutely rightly put, because the correct clinical scenario and the clinical context, along with safety of the patient, is something which everyone has to take into consideration before performing this. So, moving on to the next aspects, because we spoke about diagnosis and all, so let's move on to the treatment aspects. So Dr. Amrish, how quickly, and this is again a topic which a lot of people do ask, especially on a day-to-day basis, that how quickly should antibiotics be started once VAP is suspected? Is there still room for wait and watch approach? You're on mute, sir.
If you suspect your patient having end up in VAP, and patient clinical condition is deteriorating, then there is a no scope to wait, because if you wait to get the sample means culture positive and other biomarker positive, then it would be creating a problem. But I know my ICU has Acinetobacter or Klebsiella or Pseudomonas, then I know because of this contamination and my patient develop web, then we should consider that antibiotic empirically without wasting the time. So, in this situation, simultaneously do whatever requirement of sending a cultures and other lab report, but simultaneously should start antibiotics. So, my take home is you have to start the treatment, then send the culture, send the investigation, and modified according to patient clinical condition and whatever result you can get it.
Yeah, I think the underlining theme of all the questions almost is clinical decision making. So wait and watch can be structured, but has to be time limited and supported by close monitoring, not just passive delay. Dr. Jacob, an important question because we've been talking about all of this, but what about antifungals? Like, when will we consider antifungals in a patient with suspected VAP? I know I'm jumping the gun, but still, where do you see antifungals?
First thing, if I get a candida in the ET aspirate or ball or mini ball, I never treat it. We never treat it. So when you're talking about antifungals in the patient with suspected VAP, candida is out. We should not be treating a candida because the incidence of a candida pneumonia is probably less than 0.001%. So you are thinking about an invasive fungal infection such as Aspergillus or mucor, and that's the case when you are thinking to treat this as a patient with VAP or a patient who has a pneumonic patch, patient on a ventilator having a pneumonic patch. So obviously the risk factors for Aspergillus or mucor has to be immunosuppression, prolonged neutropenia, your hematological or malignancy, onco patients, or probably patients who are on prolonged steroids, uncontrolled diabetics. So these are the patients whom we'll think to start them on treatment. But again, before treatment, I would like to have a patient imaging. So I know that because I can see the ground glassing there or the halo sign there, reverse halo sign there. And also I'll send the biomarkers, probably BAL, galactomannan, or beta-glucan. Beta-glucan doesn't work for the mucor. But again, sorry, galactomannan doesn't work for the mucor. But again, I'm just saying that we do send the BAL fungal biomarkers also. And that's where I'll try to start antifungals in these patients.
So you did mention about Candida, Aspergillus, mucor. What about patients with chronic lung diseases, structural diseases, who keep having exacerbations, who keep requiring antibiotics and steroids? And these are all risk factors for fungal diseases. So where do you draw the line? And is there any specific test or something that after so and so days my patient is not getting better, I would rather send it? Or rather, maybe what I'm trying to say, do you routinely send fungal PCRs or galactomannans, and what would be your cutoff?
So again, if a patient, example, a COPD patient who has come in is not improving, the patch is not improving, then of course we do send the fungal cultures. And if the fungal cultures come positive, then we do send the galactomannan. And also there's something called the ASP-ICU criteria, where you can look into it and see how the score goes in. But again, this will be probably my first diagnosis will always be a bacterial. And only when I get a fungal positivity or patient is not resolving or the pneumonia is worsening, the shock is worsening, will I start thinking about that. So probably it will come down 72 hours after my antibiotic therapy.
Right. No, I think points are all well taken. Candida, disregard. Empiric antifungal therapy may be justified in a critically ill high-risk patient with strong invasive aspergillosis signal when the diagnostics are pending, of course. So Dr. Utsav, many ICUs, and of course everywhere rather, Dr. Debraj also showed a slide, we are seeing increased carbapenem resistance. So where do these newer antibiotics fit in today?
So, sir, this is a very controversial thing. This is probably one of the most important challenges we are facing in our ICUs today, that there is increased carbapenem resistance like KPC, NDM, and OXF48. The newer beta-lactamase and beta-lactam inhibitors combining have transformed treatment basically. We have this ceftazidime, avibactam, you mentioned in the presentation also. The sponsors of the day, Cipla, has a very nice product called Elores. ceftriaxone disodium EDTA with sulbactam. I personally used it. It's very good product. Not promoting the company or product, but I'm just telling you the personal experience of the product is very good. Also, there is meropenem, the imipenem relibactam and meropenem veberobactam. Many combinations are available. Newer products are coming in by multiple companies which are in pipeline, which are useful, can be used when you have. You should develop a habit of having a sensitivity pattern done according to the local antibiograms, and you involve your microbiologist in your decision making. And it should be a team decision of starting the antibiotics, not an individual decision. Again, with the ICU intensivist, with your microbiologist involved in the decision making.
Yeah, I think important thing is to have those antibiograms, and all the ICU should have that, because that is something which gives the maximum information. And whenever you're considering empiric therapy, and that is something which usually is successful more often than not. So that's something which is take home.
One size does not fit all.
Absolutely.
The right new antibiotic for the right resistance.
Yes, please.
Right new antibiotic for the right resistance pattern. We should just have it.
No, absolutely. And that is where I think sometimes the multiplex PCRs also help identifying those resistance genes.
Yes.
So Dr. Vidushi, regarding de-escalation, when do you think therapy should be de-escalated? Again, because it's very easy to start, very difficult to take those out, or rather de-escalate. You wait for culture reports, biomarkers, or again, is it based on your clinical bedside clinical decision making?
I would say it's one topic which is most talked about but least done, I believe. We all might quote a lot of guidelines. In the end, we are managing patients, and the decision to de-escalate is very difficult. So let's talk about all three topics: culture, biomarker, and procalcitonin. Culture, whether it is positive or negative, helps us identify what is going on. It is not the sole decision to treat the patient. We have a lot of culture negative cases of VAP. We do not identify all of our microorganisms, and still we continue treatment. So absence of culture positivity would not lead me to de-escalate. But a combination of culture negativity with clinical improvement or absolutely no response to my given treatment would lead me to reassess what is my diagnosis. So if I have found other reasons for the worsening, so I can completely remove my diagnosis of VAP. Say I did my lung ultrasound, found it to be a pulmonary edema, which had bilateral opacities, and my culture is negative, I would de-escalate at that point. So that should be one point. Another thing is biomarker. The most common biomarker that we use is procalcitonin and CRP. The Precepsin, and these are research tools. We do not mostly have access to that. So procalcitonin, yes, to de-escalate, I would say it is helpful because it has a very high sensitivity for bacterial involvement and a negativity, that is a fall in procalcitonin. So more than 80 to 90% fall in procalcitonin with a clinical improvement, I would say de-escalate. But if you miss that clinical part, nothing can be done. So clinical improvement along with, procalcitonin biomarker, you have culture negativity, then I would consider de-escalation. And de-escalation doesn't just mean stopping antibiotics. De-escalation also means the reducing from a broad spectrum to a narrow spectrum antibiotic. So if a culture positivity gives me that this organism is, say, maybe a methicillin sensitive Staph aureus, or maybe a sensitive Enterobacteriaceae, then I would simply come down to my de-escalation and one single antibiotic that is working. That's my take, sir.
No, absolutely. I think you said a lot of things out there, but an important part is that, yes, once you've started an empirical therapy, take a look at those cultures, see according to your sensitivity pattern if a lesser antibiotic will also work, narrow down your spectrum. Second is your biomarkers, which is your procalcitonin, CRP. See the trend. Of course, that always helps. And deciding when to stop also, rather than de-escalate. And finally, what is more important is clinical improvement also. Not always radiological resolution is what you're targeting out there. So with that, the duration of therapy, Dr. Debraj. Earlier guidelines, 10, 14 days. Now, I think 7 days is widely recognized and recommended. Which are those patients who still deserve a 10 to 14-day therapy, Dr. Debraj?
Sir, in those patients in which we have an MRSA or we have an MDR Acinetobacter or MDR Klebsiella or MDR Pseudomonas, in those patients we will give a treatment for at least 10 to 14 days. Also, in those patients in which particularly we have an empyema-like thing, or we have some additional infection which is localized to any other organs, particularly GI associated sepsis with VAP, in those patients we will give at least 10 to 14 days of antibiotics.
Right. Now, I think that's an important point you raised regarding, say, Acinetobacters and other organisms, say, Pseudomonas, because the guidelines also mention that just because you are dealing with, say, a Pseudomonas or an Acinetobacter, do not really increase your therapy duration. But yes, if you have an ongoing infection, if you know that your patient is not really improving, not on the verge of improvement, rather, you have other, say, complications such as lung abscess, necrotizing pneumonia, maybe empyemas, cavitation, bacteremia, or seeding in or a proper localized source somewhere. That is maybe when you can increase the duration of your therapy. So yes, not everyone requires a 10 to 14 day, but at the same time recognize those conditions where a longer therapy may work, because otherwise treatment failure can be catastrophic in these patients. So nebulized antibiotics, Dr. Amrish, do remain controversial. What is your experience? Where do you currently use them in ICU, and how have the results been?
Nowadays, available of very good injectable antibiotic. Like when you see which antibiotic you are giving for nebulized from, only colistin and aminoglycoside. But particularly when giving a colistin, making a formulation, giving to the patient without creating a problem is very difficult. So since many years we are not using a inhaled antibiotic routinely. We prefer to give injectable antibiotic, but in certain situation like patient having bronchiectasis or severe COPD, in whom along with the bronchodilator we can sometimes use aminoglycoside, but not a colistin we are using regularly, because there is a no clear cut guidelines available what are the dose that you have to give to the patient to reach a alveolar fluid. And also when you see a 1 million unit vial, and when you formulate in a solution, and when you give with a jet nebulizer or ultrasonic nebulizer, your most of the medicine will remain in the nebulizer. So psychological or emotionally, we feel we have given the medicine to the patient, but practically when you see, your medicine will remain in the circuit or in nebulizer kit. So since many years we have not given a inhaled colistin to our patient, but proper dose, duration, when you select, then these medicine not required.
Absolutely. I think points all well taken, because what also matters is your drug delivery. How is it going, your circuits and all. So with that, Dr. Jacob, your experience with these inhaled antibiotics, do you use them? And if you can just shed some light on what would be the appropriate way of giving these inhaled antibiotics, and should they be used in conjunction? I mean, can they be used as monotherapy or as adjunct with your IV therapy?
So two things. Again, as sir already mentioned, it has to be the use of inhaled antibiotics have come down drastically. We understood that it's not helping much of our patients. Now, where do I use it? Probably if I have an MDR bug, or not an MDR, an XDR bug, which is susceptible only to colistin, bodymyxin, etc. In those cases, I may have to use it in conjunction with the IV therapy. So basically, I don't use, or you cannot use nebulized drug alone as a monotherapy. It has to be used in conjunction with your IV therapy. and probably we use it only if probably it's the last resort, no other IV drugs are available, and cholesterol polymyxin has to be given. So that's where we use it. But again, how we are using it is also important. Just as sir also mentioned, you have to optimize your ventilator settings to the volume control ventilation, increase your inspiratory time to the maximum, reduce your respiratory rate, do a thorough suctioning, give a bronchodilator nebulization, and then only give this through a vibrating mesh nebulizer. Your jet nebulizer won't help you. So, so doing it properly is also extremely important. And probably the only patients that we use it is XDR patients who are susceptible only to cholesterol.
Absolutely. I think a lot of studies have also showed that, yes, it can possibly help in microbiological eradication and maybe clinical cure. But so far, nothing has shown improved survival. That is one of the things. And important is what exactly you're using. Inline mesh nebulizers usually are the ones which are used, and it has to be synchronized with your ventilator, proper humidification. And of course, if your patient has a lot of secretions, it may not really reach the target. So suctioning before that is also another important thing. And do monitor for bronchospasm because it can precipitate bronchospasm. So these are certain take-home points if you're using those inhaled antibiotics. So Dr. Utsav, what about treatment success for VAP? Is it clinical improvement, microbiological clearance, or radiological resolution? Dr. Utsav, are you there? Yeah, you are on mute.
Sorry. So I think clinical improvement, treatment success is primarily a clinical endpoint, not a microbiological or a radiological endpoint. So clinical improvement includes improved oxygenation, reduced fever, hemodynamic stability, decreased inflammation, reduced ventilatory requirement. These are the primary clinical endpoints I think are required. And reduced ventilation requirement, radiological infiltrate often lag behind clinical improvements. A patient who is clinically improved and no longer demonstrate ongoing evidence of active infection is said to be clinically improved.
Right. So I think we are ending or we are towards the tail end of this whole thing. So a few quick questions. We have covered VAP mostly. We'll move on to HAP, HCAP and whatever. So Dr. Amrish, one question to you. What is the primary difference between HAP, HCAP and any related terminology, and are these still useful?
So like HAP is we consider as a hospital acquired pneumonia. Any patient admitted in ward or ICU and after 48 hours, if they develop pneumonia, then we consider as a hospital acquired pneumonia, and preferably it should not be intubated or mechanically ventilated. And HCAP is healthcare associated pneumonia. Any patient having an exposure to healthcare facility, like sometime patient came to hospital for care procedure like receiving antibiotics or per se like dialysis, or they receive some form of treatment like physiotherapy or any home care therapy, or if they get an infection from their relatives from MDR infection, then we consider as a healthcare associated pneumonia. But like in 2016, this healthcare associated pneumonia terminology is out. So we consider they set this terminology as a cap, because what happened if we consider as a healthcare associated pneumonia, then people are treating like hospital acquired pneumonia. So there is an inadvertent use of higher antibiotic, and when we see the type of infection or severity infection, then it is similar to community acquired pneumonia. They are not a MDR bugs; they are a very less virulent organism. So they remove the from the 2016 guidelines, and they consider like you should consider as a cap like illness. So HAP and we consider as a HCAP is like cap.
Yeah, no, absolutely. I think HCAP or healthcare associated pneumonia taught us to notice healthcare exposures, but the label was actually too blunt or broad, and risk factors in prior microbiology are more useful than a category. So, Dr. George, how do you assess MDR risk in hospital acquired pneumonias? Is prior hospitalization enough, or should we rely more on previous cultures, recent antibiotics, and local antibiograms?
Yes, prior hospitalization is not enough. The the most important or most important thing will be your previous isolation or colonization of your MDR bugs in these patients. Then second thing will be history of IV antibiotic exposure, especially the broad spectrum antibiotic exposures in the last 3 months. And third thing is you should know your antibiogram or your ICU bugs. So if a patient is going to get a infection from your hospital, it has to be from, you should know what it's going to be. So that's again, or if your patient is being referred from another hospital, that local ICU antibiogram makes a difference. And fourth thing is again the severity. If a patient is in septic shock, not improving, then probably your threshold of diagnosing an MDR is a bit on the lower side. You will go with the broad spectrum antibiotics. So your structural lung diseases, prolonged ventilation, patient receiving renal replacement therapy, and your ICU the ICU antibiogram. These are the things that are extremely important to suspect and treat empirically with broad spectrum antibiotics.
Right. Dr. Vidushi, I think an important question for you, and maybe a little longer answer or whatever. What would be your choice of empirical therapy in a patient with HAP? And specifically when you're considering, say, MRSA or say maybe Pseudomonas, what would be your choice of empirical therapy?
The empirical therapy in HAP is quite similar as what we consider based on the patient's underlying condition. So if you have a patient with HAP, but the patient has septic shock, patient could get intubated or has been intubated, has had ARDS, I would treat with maximal therapy that I can give, where I would treat with my anti-pseudomonal agent with MSSA coverage. And in presence of shock, I would consider 2 anti-pseudomonal agent, especially considering we are patient population where we mostly have patients who have had underlying exacerbations or previous exacerbations. In terms of MRSA coverage, sir, I seriously consider that is a very important policy for antibiograms. While most hospitals do not actually have their antibiograms, that is an unfortunate truth. But most of us would be able to realize whether we have MRSA or not. If you have less than 20% MRSA, there's no point empirically giving MRSA coverage to most of these patients. Regarding selective patients where you do not have any risk factors, we can have some patients first episode of a COPD exacerbation admitted, now develops HAP, has previously not had the IV antibiotics, no other risk factors, does not have structural lung disease, and does not have any shock. I can consider a single agent anti-pseudomonal agent with MSSA coverage, and I would be happy with the piperacillin tazobactam alone. Or if I am considering a meropenem alone, that can be considered in stable such kind of patients.
Yeah, no, absolutely. So I think broad therapy should be dependent on patient severity and resistance probability, and not automatically, conferred by earlier hospitalizations alone. So that's an important message. Final comments, Dr. Debraj sir. If you could just change one thing about current approach to VAP or HAP worldwide, what would it be? And your message towards the end of this panel discussion.
So, 2 or 3 suggestions. And number one, USG is still not incorporated into the guidelines. So, we should put more emphasis on the USG. Second, I will put more emphasis on bronchoscopy. Whatever be the guidelines saying that ET semi-quantitative culture is as comparable to bronchoscopy. Me myself being a pulmonologist, from my experience, I can tell you patient not responding, doing a bronch and sending the sample for culture or sending the sample for biofire. If it done by a trained pulmonologist, then I will put some point of emphasis on bronchoscopy. And third thing, which I am in little bit of favor, that in whatever antibiotics what we are recommending in guidelines are mainly for Western countries. In Indian ICUs and particularly in patient what we are treating the respiratory or pulmonology patient, I think it is not wise to start the patient on those lesser spectrum coverage antibiotics. So we should be, although we should not start straight away with ceftazidime, avibactam or those kind of thing, but at least depending upon the factors. So if my patient is worsening, if my patient is having some kind of septic shock suddenly after 2 or 3 days after being put on mechanical ventilation, so I will straight away jump to probably knowing that my patient is having Klebsiella or Acinetobacter, what is more prevalent in my ICU. So in that thing, I think that we should be more rational in our Indian context.
Absolutely rightly said, sir, and all points worth noticing. Of course, practice changes place to place. In fact, we also do a lot of bronchoscopies, but I'm not sure whether that's the right practice. Only if you could collect all the data and document, maybe we'll be able to comment on it more conclusively. So I think we'll just take a few audience questions. So we'll just go in sequence. So Dr. Amrish, Dr. Priyanka from Tumkur asks, what is the management for pan drug resistant VAP? Broad question.
So it is very difficult situation when you encounter, then just properly counsel the relative also. But when you see from medical aspect, you should collect your antibiogram, particularly because nowadays, as some of the hospitals are not publishing that antibiogram. So, as a ICU consultant, you always ask your microbiology department to get the antibiogram. But nowadays, newer drug available like ceftazidime, avibactam plus estrionam or avibactam plus estrionam, along with polymyxin or colistin, preferably you can use in this type of situation. And like Dr. Kumar Utsav rightly says, ceftriaxone, EDTA plus salbactam, we have using in many cases. This is, I think, underrated drugs. But we are routinely sending these for sensitivity, not only in radial secretion, but also in blood culture sensitivity, as well as in other sensitivity when we encountered this type of pan drug resistance or XDR organism. And except for Pseudomonas, we can use very well this drug. It has excellent penetration, excellent clinical response. So we should consider this type of medicine in our practice, but get some clinical experience, then and only you should use it.
Right, sir. Dr. Jacob, Dr. Satyaranjan from Bhubaneswar asks about prevention of HAP and VAP. We took it. If quickly you can just summarize. Maybe VAP bundle he's talking about.
Before the HAP and VAP, whatever bundle you are taking, the most important is hand hygiene. So each one of us, even before we ask our nurses to do it or the respiratory therapists to do it, each one of us have to be masters or warriors for hand hygiene. There are 5 moments of hand hygiene before touching a patient, after touching a patient, before any procedures, after body fluid exposure, after touching the patient's surroundings. So when you move from one bed to another, even if you touch a patient's case file, you should be doing a hand wash with chlorhexidine. Then you have the VAP bundle that varies from person to from your institution to other institute, but broadly, head and elevation, try to remove them as fast as possible, early liberation from the ventilators, and the subglottic suction is something, if your rates are very high. If rates are really not that high, subglottic suction may not help you, but otherwise, probably head and elevation, chlorhexidine, daily toothbrush cleaning, awakening, from the awakening from the stopping the sedations and trying to liberate them faster. And your hand hygiene is the most important things to prevent your VAP rates or MDR rates in the ICU. And I would say that hand hygiene is something that is extremely underrated by doctors itself. So we have to focus on that.
Right. Dr. Utsav, Mr. Nursing, Dr. Nursing Rajpurohit asked from Jodhpur, why is VAP so common these days? I think it has always been there.
VAP is common these days because you are
diagnosing.
more easily availability of ventilators, and more patients put on ventilators, and good anesthesia backup these days we have in our hospital, so we are comfortable in intubating the patient, and we are able because of increased number of patients, the hand hygiene phenomena not being followed because of cost of gloves and sanitizers and everything included. So VAPs are increasingly seen nowadays, and we have increased we're increasingly looking for it in our ICUs. We're increasingly looking and trying to treat it. That's why we are able to encounter these more often than not.
Absolutely. Dr. Vidushi, one Shehbaz Saban from Mumbai asked, what is the current definition of VAP and how does it differ from ventilator-associated events?
So I think most of this was covered by Dr. Debraj quite well. But to summarize, all VAPs would be ventilator-associated events. Not all ventilator-associated events are VAP. So you have in ventilator-associated events, you have ventilator-associated condition where any change in ventilator parameters, including oxygenation or which required a higher oxygenation, FiO2, lasting for at least about, I think, 48 hours is there. If you have other features of inflammation, you call it a ventilator-associated condition, which is infection-related. And once you have microbiological confirmation, that would be a possible or probable VAP. But these terminologies are actually research tools. The ventilator-associated events, these were diagnosed, designated by the CDCs for research purposes. What we practically used are clinical diagnosis of VAP.
Right. Dr. Debraj, Pranav from Delhi asks, which steroid is preferred for severe CAP, not in shock?
So, sir, I will not give any kind of steroid in patient who is having severe CAP without shock. So, I will prescribe only for those patient of severe CAP with shock. Only in the viral pneumonia, later on after take it as 7 to 10 days with a stiff lung, the oxygenation not improving. In those subset, like the COVID ones, what we have treated for a long duration of time, so then we will give those dexamethasone, as we have we all have a huge experience of treating the COVID patients in the later part of those, in the later part of ARDS. Apart from that, sir, if my patient is not in shock, I will not give any kind of steroids.
Right. I think what possibly Pranav is mentioning is the recent NHM paper, 2023 or 4, I believe,
Yes.
which mentioned about steroids or hydrocortisone specifically in severe CAP, which actually showed a benefit in mortality.
The COPA publication. So it is also clearly mentioned there in those patients in which who is having shock in spite of NORAD and vessel.
Right. Yeah. And Shikha Jindal asks, one Ashish Kumar Jha from Patna, Bihar asks Dr. Amrish, what are the major risk factors for developing VAP? I think we've already covered that. So another question by Dr. Shikha Jindal is, okay, she's given you a task to compare ceftriaxone, sulbactam, durlobactam, ceftazidime, avibactam, meropenem, vaboravactam, and so on. So basically all the newer antibiotics. I think what she basically means is that where do these particular things, or rather which organisms do they work specifically for? And I think we can possibly classify them into 3 major categories: the Klebsiella KPCs, Enterobacterales, and the Pseudomonas, and finally the Acinetobacters. I think that is what the thing is. Care to elaborate, sir?
So first of all, whenever you get the culture report positive, if possible, send for enzyme detection, because nowadays understanding the enzyme, like whether you are dealing with the OXA or NDM or KPC. So depending upon these enzymatic, if you understand, then and only these newer antibiotic will definitely you will cover. It is not like blanket you can use in each and everything, because for research purpose and to save the antibiotic and treat the patient, you have to understand these organism. Like whenever you get the blood culture positive, because it's a sterile site specimen. So whenever you get this patient of sepsis, you send the blood culture for enzymatic detection. But similarly, for respiratory secretion, whenever your institute having these facilities, you have to send for the enzymatic detection. Then and only you consider like these newer antibiotic, because pharma company and other, they are very limited knowledge and they are not showing the proper outcome. So we have to understand why these and newer antibiotic will cover this particular organism and to my this serious patient. Then and only use this organism. Like I told you about ceftriaxone EDTA. If your culture is showing OXA 48, then you definitely use this ceftriaxone EDTA salbectam. But if it is showing NDM, then you cannot use this. So understanding the enzyme is always important.
Yeah, if I may, majorly your Cephtas avibactam or Astronam avibactam, so these may be good for your KPCs, OXA48s and all. Pseudomonas, yes, also to some extent, but they don't really work against your Acinetobacters, and that's where your colistins or maybe your sulbactam-based combinations are useful. Dr. Utsav, can you mute yourself, please? Okay, Dr. Jacob. And Dr. Asmita from Ernakulam and Dr. R.K. Gulia, they both have similar kind of questions. What are the current controversies in VAP prevention, and which components have the strongest evidence and which do not work? I think Dr. Debraj also covered that, but if you can just quickly summarize this.
So first thing, the selective digestive decontamination, the data that we have is basically from the countries that have a really low drug resistance. So in countries where ampicillin, amoxicillin is still the first line of drugs, those areas, the Scandinavian countries, these are the countries from where you have the data of selective SDD. So is that really applicable in our scenario? Probably I'm not sure, because our drug resistance is quite high. And to use polymyxin paste for all our patients, I'll be really a bit scared of, because of the worry of more increasing the drug resistance. Now, when it comes to VAP prevention, the most important thing is the best evidence is not to intubate. So as long as whether if you can tide over with your HFNC or tide over with your NIV, well and good. Or probably if you say that your hand hygiene, yes, it has a very good, it has very strong evidence for preventing your VAP rates. And third thing will be probably your this oral care without chloroxidine. So chloroxidine has shown to increase the incidence of chemical pneumonitis. Rather, the only subset of patients where chloroxidine has reduced VAP is in your post-operative CTVS patients. So other than that, in our medical patients and all, just as routine brushing is beneficial. So chloroxidine has come down from the VAP bundle. And subglottic secretion really seems good, but again, if your basic fundamentals are correct, if your hand hygiene is correct, only if your other components of VAP bundle like a head and elevation is there, then only this subglottic suction helps you. Closed suction seems intuitive because you're not opening the circuit at all. But again, there is no data to include it into your VAP bundle. Continuous cuff pressure control around 20 to 30 to prevent microaspirations also has some evidence for preventing the incidence of VAP. So I think that's it. Mainly it is hand hygiene. So mainly it will be reducing the incidence of intubation, early liberation from ventilation. Third thing will be hand hygiene, and fourth will be your oral brushing and come down on chloroxidine. So to prevent the incidence of chemical pneumonitis.
Okay, great. So now it will be more of a rapid fire. We still have a lot of questions to go and not enough time. So Dr. Utsav, Tridip Chatterjee from Mumbai asks, how does duration of mechanical ventilation influence pathogen profile and prognosis?
So the duration of mechanical ventilation does not influence. It depends on your the standard of care you provide. If your ICU team is well equipped in managing, then the risk of VAP and HAP decreases significantly.
Right. Dr. Vidushi, Dr. Ajay Lanjevar from Sevagram is asking what is the role of microaspiration in VAP?
Microaspiration, we all have been considering for a long time that it causes pneumonia in a lot of susceptible patients. So, if you have more microaspirations, especially in patients who have reflux, you might have more VAP. And that is why head end elevation to more than 45 degrees is such an important HAP preventive or VAP preventive strategy. So, yes, microaspiration does have a role, but methods which can help reduce it are also there. So we can easily manage with subglottic management of cuff pressures and patient positioning.
Yes. Dr. Debraj, Dr. Sunita from Thrissur asks, how does biofilm formation on the ET cuff contribute to VAP?
It does.
Yeah. So, okay. Hari from Kolkata asks, what are the common empirical antibiotics to start in hospitalized patients? Dr. Amrish.
So, this is a very broad question. So, not each and every patient hospitalized require antibiotics. It's depend upon why patient is hospitalized. If your patient is for say surgical, then there is a no only surgical prophylaxis is required. But like your patient is, I narrow down the your question. If your patient is admitted with respiratory infection, then this patient first and foremost, you have to decide whether my patient is suffer with bacterial infection, atypical pneumonia, or viral pneumonia. Then and only you can start empirical antibiotic. Otherwise, if you have like flu season, then it should be like flu illness or COVID. Or if your patient is having an atypical pneumonia, then this patient does not require a very high level of antibiotic. Just simple atypical coverage antibiotic like doxycycline or quinolone or macrolide is sufficient. So it's depend upon condition to condition. Then and only you decide which antibiotics.
Dr. Jacob, Dr. Vishwesh from Thane asked, what are the common pathogens causing early and late onset VAP? Quickly, please.
So the late onset VAP is usually your MDR bugs like your Klebsiella, Pseudomonas, Acinetobacter, etc. Early onset VAP is mainly from the oral pathogens. You still have drug sensitive bugs like your Streptococcus, and drug sensitive Enterococcus.
Right. Dr. Vidushi, Dr. Atif asks, what all supplements to give to patients of HAP and VAP? Not sure I got that question, but yeah.
No supplements. Treat the patient with antibiotics, and supportive management would include the enteral nutrition. I think that should be the supplement enough. High protein diet would be
Yeah, so Dr. Gyan Shankar and Dr. Naimdar both asked role of inhaled antibiotics. I think we've already covered that. Yeah, important question, Dr. Utsav. Rizwan Khan from Nanded asked, what is the relationship between VAP and ICU acquired weakness? Or anyone can take it, Dr. Jacob, maybe.
Yeah, so whenever you have a severe infection, whenever your inflammatory markers go up, you tend to have increased critical illness myopathy. Second thing, your drugs that you're going to use, colistin, polymyxin, are also neuromuscular damaging agents. So they can also increase your ICU-acquired pneumonia. If your patient is in septic shock, you are going to use steroids. So the cumulative effect, your uncontrolled diabetics, steroids, and so all this will increase your critical illness myopathy. So coming straight away to your question, the more severe VAP you have, the more likely that you use multiple agents are going to come into flow to get increase your ICU-acquired pneumonia. Sorry, weakness.
Yes. Anna Fatima asks, what are the predominant MDR pathogens causing VAP in Indian ICUs? That Klebsiellas, Pseudomonas, and Acinetobacter, and MRSA most commonly. Siddhi from Mumbai asks, when should fungal pathogens be considered? We've already covered that in detail. Cyrus asks from Indore, what clinical criteria used to diagnose VAP? Again, we've covered that in detail. And what are the limitations of CPIS score? I think it's majorly interpersonal variability, which is there. Yeah. So one important question, Dr. Debraj, Raj Purohit from Jodhpur asks, what are the quantitative culture thresholds which are significant for ETA, BAL, and brush specimens, protected brush specimens? Dr. Amrish, you would want to take that?
So particularly like semi-quantitative, you can consider for 10:3 colony forming unit per ml. And for BAL, you may go for 10:4 colony forming unit per ml.
Right.
कल सुबह रिकॉर्डिंग करवा दें, आज छोड़ दोगे? 10:30 ऑलरेडी बज रहा है.
Okay, these are the questions. Yeah. So, one Dr. Aniket asked Dr. Vidushi, when is dual gram-negative coverage indicated?
If you have a patient with sepsis with septic shock, and you have a risk factor for multiple drug-resistant organisms with underlying structural disease, maybe then we would consider dual gram-negative coverage, not in all cases.
Right.
I think for Acinetobacter, you have to give dual coverage for all patients.
Yes.
So, sorry, I was talking about empirical coverage. So if you do get an organism, and then you will have to consider, and if you have a simple organism like maybe Pseudomonas, which is pan-sensitive, then maybe we do not even need dual gram-negative coverage unless you have structural lung disease. Otherwise, yes, sir. Well taken. Acinetobacter, we would prefer dual gram-negative coverage.
Dr. Jacob, when should empirical MRSA cover be started?
That depends upon your local antibiogram. If you have a MRSA coverage baseline more than 30%, yeah, you go with empirical MRSA coverage. If you have a neutropenic patient coming with sepsis, septic shock, and a neutropenic patient coming with a radiological patch, you will go with MRSA coverage. Post-influenza, if you think your patient has a high risk for MRSA, again you go with MRSA coverage. But again, from the Indian data per se, probably empirical MRSA coverage is slightly low on my list.
Yes. Tina Anand from Delhi, what is recommended duration for antibiotic therapy for VAP? We've covered that. 7 days can extend to 10 to 14 days in specific conditions. Finally, one question to Dr. Amrish. How do you manage VAP caused by carbapenem-resistant Acinetobacter baumannii? Last question.
So as previous speaker already, we have to start with dual antibiotic. So I think in preferably scenario, particularly for lung involvement, we can go with tigecycline. In our clinical experience, we can go with tigecycline plus sulbactam because both the antibiotic has good lung penetration. If my patient having bacteremia, then I may choose to another drugs like ceftazidime avibactam plus estrionem, or even my respiratory secretion, so Oxa 48, then I would go with ceftriaxone sulbactam EDTA along with colistin if my patient is very sick. So there are multiple options available, but depending upon your resistance pattern, system involvement, and other contributory situation, you have to select.
I have a question to the panel myself.
Yes, please, Dr. Utsav.
Yes, experience of the panel of colistin versus polymyxin B in ICUs.
So
if I may take this, colistin, so generally for us, majorly it's polymyxins because it has got good extracellular lung fluid penetration, so it works really well for primary lung infections. But yes, whenever we have, say, complicated UTIs and all, that is where we prefer colistin. More importantly, of course, we always see whether there's any other antibiotic which is available or not owing to toxicity. And obviously, the loading dose and what is the maintenance dose that really matters based on the GFRs and all. But overall, for VAPs, for lung infections, polymyxin works really well.
The odd point is you cannot use polymyxin for nebulization. So if you are thinking about nebulization, you have to use colistin for nebulization.
So can we mix colistin with nebulized colistin with polymyxin B in nebulization? With polymyxin B?
Difficult to answer data-wise, but that's what people do. Yeah.
Yeah.
Yes.
Right. Regarding the carbapenem-resistant Acinetobacter baumannii, probably your backbone has to be a sulbactam, irrespective of your sulbactam sensitivity. So even if your sulbactam is resistant, you will go with a high dose sulbactam, and you will need two drugs. So just as sir told, if you can use polymyxin, colistin, and again we had discussed about your inhalational drugs. So this is one area where you may think about inhale colistin along with your IV polymyxin if you want to use it. Tigecycline, Sarah's correctly told that you can use it, but again the dose has to be at least double the dose of our usual dose. So 200 mg will be the loading dose and 100 mg BD, or you can go with minocycline. That depends upon your drug sensitivity. So you cannot assume that a bug which is sensitive to tigecycline is sensitive to minocycline. There is difference in that. So depending upon your susceptibility, you will need two drugs. One backbone has to be sulbactam, and then you have to think about the other drug. And the guidelines, or if you look in the Sanford, they will say that even if it is meropenem resistant, you can still use imipenem along with it to avoid monotherapy.
Just one more question to the panel. Sorry. Experience about use of inhaled tobramycin nebulization. Inhaled tobramycin nebulization.
Yeah, so we use it. All of us use it probably. That depends upon the culture sensitivity report. So if you think that you have a patient with sensitivity, especially Pseudomonas or COPD patients with structural lung disease, we usually do it. Yeah, we do it.
If your culture is suggestive of sensitive to aminoglycoside, then it is wonderful drug because it is commercially available for giving a nebulized therapy. So whenever your antibiogram shows tobramycin is sensitive, then you definitely use and preserve other antibiotic also.
Okay, thank you, sir.
Yeah. So just quickly, I think I'll take one comment from everyone. Just your take-home message from management of HAP, VAP, like whatever you would want to tell to our audience. Dr. Amrish, we'll start with you.
So first of all, I would thank to all of you for your wonderful support. And take-home message from my side is, first is avoidance of conditions. So first is try to prevent getting into this situation. So always follow hand hygiene practice in your ICU or in the ward. Another second is you have to diagnosis. Like there are bedside diagnosis you can think about. Like there survival sepsis guideline says 2026. They says you have to ask 4 questions to yourself. First is if oxygen saturation is going worse or not. If it is yes, then you have to think about VAP. If your systemic inflammation is there, like patient having fever or WBC, if there is lung inflammation is there, like purulent secretion, and if there is a new radiological process is there or not. If your 4 question is tick, then you consider about the VAP. And finally, after getting diagnosis, depending upon culture situation, culture report, you have to modify your empirical antibiotic and try to preserve your antibiotic for the future patient and your future condition population also. Thank you, everyone.
So I think Sarah summarized beautifully, leaving us no options for us to come fill it. Every point were touched by Sir. But again, as Sir said, you have to be strict with your hand hygiene. You should know your antibiogram excellently, and you should know what is the most common etiological agent in your hospital and treat accordingly. So it's always a good discussion with your ID, microbiology, HIC nurses that helps it. And always keep a mark of your HAP rates, VAP rates along with other rates. So that will benchmark you against other, it will benchmark you and help you to improve also.
Absolutely. Dr. Vidushi?
Well covered already, but I would say that personalized empiric therapy rather than a broad spectrum. So your personalization of an empiric therapy based on your patient's condition and an alternative etiology to always be considered, alternative to VAP. And once everything has been confirmed, to de-escalate aggressively. That's my take home for today.
Great. Dr. Utsav, any closing comments from your end?
Sir, I think we have done a very descriptive discussion, HAP and VAP, and this has been one of the most descriptive discussion, most learning discussion. The take-home message would be that be alert, rather than go for a PCT, CRP in the beginning to know how tough a patient you are dealing with, and a PCT CRP will go a long way in helping you out in diagnosing your condition at the beginning, and then move ahead and keep following the X-rays closely, and then move ahead and diagnose a patient early and send a culture fast and talk to a microbiologist about newer antibiotics and what can you do best for the patient to get ready, get treated fast. Thank you.
Great. So, on behalf of us all, I would like to thank all the audience for sticking together till the very end. And it was indeed a very informative sessions talk by Dr. Debraj, followed by useful comments by all the panelists. I thank you all my panelists, all the speakers, and of course the organizing committee, the technical team, Vipul, everyone, and of course ICS, Dr. Nene ma'am, and Dr. Chawla for making this happen. Thank you all. I hope you all benefited from it.
Thank you.
Thank
Good
you.
night.
Thank you.
Good night.
Thank you. Good